right, that makes 12 o'clock. Thank you everyone so much for joining us this afternoon for Missouri Rural Crisis Center's Defending Medicare webinar. My name is Jamie Blair, and I'm an organizer here at MRCC. We're a statewide farm and rural membership organization with over 5,600 members across the state of Missouri. When we heard about this issue, we knew that we needed to bring it to your attention as soon as possible because Medicare is such a vital part of rural and urban families and communities. Just a little housekeeping before we get started. Please feel free to ask questions using the Q&A feature throughout the presentation. I'll be keeping an eye on that, and we'll get to as many questions as possible after we hear from our expert, Dr. Weisbart. I would also like to try and keep an eye on the chat, but please try to use the Q&A to submit questions you'd like us to discuss as much as possible. You can find the Q&A and chat down at the bottom of your screen. With that, please allow me to introduce our expert guest. Dr. Ed Weisbart practiced family medicine for 20 years at Rush Medical Center in Chicago, and he moved to St. Louis in 2003 to serve as Chief Medical Officer of Express Scripts until retiring in 2010. He volunteered as an assistant professor of clinical medicine at Washington University in St. Louis from 2004 until retiring clinically in 2021. He serves as president of Consumer Council of Missouri and is the Missouri Chair and National Board Member of Physicians for a National Health Program. Thank you so much for joining us today. Ed, please take it away.
There. The 2022 crisis. Stop your mute button. Unmute yourself. So thank you so much for inviting me. And I think you're spot on that this is a crisis and it really belongs to be discussed here at the Missouri Rural Crisis Center. So thank you so much, Dina and Jamie, for inviting me. I've got to tell you right at the beginning, some of what I'm going to tell you will sound hard to believe. It'll sound, how can this be real? And it'll sound like we're making this up. And part of the point is that it's not been getting much press yet, but it really needs to. It's already affecting many Americans, and we'll show you some information about it. And it's really critical that we learn and take action on this. So that we're going to talk about this movement to turn Medicare from a public service that we rely on for when we're seniors or disabled, to turn that from a public service that we rely on into a completely privatized Wall Street venture, introducing middlemen to the middle of things. So we're going to unpack that quite a bit. But first, let me sort of walk you through why it's so important to me personally. I'm on Medicare. I've been there for 3 years. I love it. And my mother-in-law is on Medicare. There she is. And the only reason I do these talks is I just love to look at my mother-in-law's picture. Hi there, Ma. So I have Ma's permission to tell you this story in case you're wondering. She lives in Florida, not in Missouri like we do. And she has frankly rare for somebody in her age group, a rare genetic condition in her heart. And it's a condition that didn't show up until her late 70s and would eventually be fatal to her. And it got to the point of being pretty darn disabling. But it is rare, and there is literally no one. There are literally no physicians in the state of Florida, where she lives, who have any expertise treating this in someone in her age group. So this is a pretty complicated treatment. You don't want somebody who doesn't have experience involved in this. So we figured that out, and we flew Ma from Florida to St. Louis, which happens to be, where one of the 3 centers in the country that have experience is located. So Washington University. So we flew Ma from Florida to St. Louis. She got this really high-tech intensive treatment, spent several days in the hospital and then several weeks sort of recovering from it, and then went back home. This was, I think, 8 years ago, and she's great. She's great. She's had 2 orthopedic surgeries since then, and she couldn't have had those, and she wouldn't have lived more than a few more months, perhaps, had she not come up here. So hooray, a good success story. Why am I telling you this? Because she has Medicare. She has good old-fashioned traditional Medicare, Part A and B, and a supplement. So she gets a supplement, and her copays and deductibles are actually non-existent. She has that. And because of that, she can go anywhere she wants in the country. Almost every doctor takes Medicare. 93% of physicians, adult medicine physicians, take Medicare, almost any hospital. So she can go anywhere she wants. And that's really important. I'm the one who managed the process for her largely, and I never called anyone for permission. I never had to call Medicare for permission. I never had to call anybody. She was able to get wherever she wanted to go. And frankly, she has one of these really good supplements and didn't pay a penny out of pocket. She, of course, pays her taxes for Medicare, has for a long time. She buys a supplement, but getting really life important care didn't cost her anything extra. She didn't have to pay a penny out of pocket. When she went back home, and this was, like I said, about 8 years ago, she never got any of these surprise bills that so many people get. So it was really, really good to her. It's really important. And she counts on it being there for the rest of her life, as do I in Medicare. So the thing we're talking about today is, in my mind, a very clear threat to that and could disrupt her ability to make these decisions on her own. And if you think you can mess with her Medicare, you don't get to see my beautiful model. You get the different version. So those of you who don't have the video running, can't see it. Trust me, you don't want to mess with my mother-in-law's Medicare. So we're talking actually about two almost identical programs. There's one called direct contracting, which is ending in a few months, and it's being replaced by one called REACH. So unfortunately, we have two names to wrestle with for the next few months: Medicare direct contracting and then REACH. They're very similar, but not the same. But they began in 2019, didn't exist before that. In 2019, this program of Medicare direct contracting was introduced as a model, and then it went live a little less than a year ago. April of 2021 was when it started happening, and we got wind of this about a month or two after that, and a whole grassroots organizing campaign began, because we thought, oh my God, this is a radical transformation of a really successful program. So a whole group of us got together and actually went to DC and started lobbying against it, and we stopped it. We actually got that program ended. Hooray! Why am I talking to you? Because in February of this year, what happened was, in response, I think, to the grassroots work, Medicare announced the end of this direct contracting program as of December 31st, 2022, and is replacing it January 1st, 2023 by a very, very similar program called REACH. So we won, but we really got little more than a name change. And so that goes live, this new version. So it's the same program, a few important differences, but largely the same program. So we need to talk about it. In theory, what we're talking about is a pilot program, an experiment that is supposed to reduce cost for Medicare. That's a good thing. It's supposed to improve healthcare for Medicare beneficiaries. It's a good thing. But the real goal of what's going on with this program is to change how Medicare pays for healthcare, change how they pay. I'm going to show you why this is incredibly important. So Medicare today pays providers, physicians, hospitals directly, but under this new program, Medicare would start giving these newly created third-party middlemen called direct contracting entities a payment instead to manage our healthcare. So Medicare has been direct, and instead Medicare is going to be is now giving our Medicare money to these new entities. And these new entities, why should you care? These new entities are allowed to retain as overhead and profit anything that they don't spend on actual Medicare, not medical care. In other words, they can keep as profit what they don't spend, so they have an incentive to restrict our healthcare. This is a whole new thing for Medicare. That's never happened in traditional Medicare before. So, as you can see in this cartoon, traditional Medicare basically just pays the doctors and hospitals on our behalf, and we go wherever we want, basically. Direct contracting introduces, as I said, this new set of middlemen to manage our healthcare. So I had somebody a couple of weeks ago say, yeah, I've got a doctor and a nurse, but what I've really needed has been a banker in the exam room. And that's kind of what this is doing. So what are these things? First, maybe use the raise your hand. I don't know if we can do that on a webinar, but I'm wondering if you've heard, anybody in the room has heard of direct contracting. It's kind of hard to see on the webinar. So let me just assume that you're like most people and have not heard of this before you started getting this message from Missouri Rural Crisis Center and today. So this is a program that's below the radar that most people don't know about. Congress doesn't know much about, honestly. And it was developed deep within the government by an obscure agency within the Center for Medicare and Medicaid, and the Center for Medicare and Medicaid. There's this agency called the Center for Medicare and Medicaid Innovation. And it's got the power to implement programs and then scale them up across the entire Medicare book of business to every Medicare member. And they have this authority to do that without getting congressional approval. So when we met with Congress a few months ago, I and a handful of my friends in my organization When we met with Congress, most of them had honestly never even heard of this, because indeed this program is allowed to proceed without congressional approval at all. So it comes out of Health and Human Services, right, which is headed by Xavier Becerra, the Secretary of Health and Human Services, who was appointed by President Biden. This is their organizational chart, just to show you how deep this is. One of the things in Health and Human Services is the Centers for Medicare and Medicaid Services. So sort of deep within Xavier Becerra's broad range of responsibilities is the Center for Medicare and Medicaid Services, or CMS, as it's often called. And then here's the organizational chart for CMS. And deep within CMS is one relatively limited center called the Center for Medicare and Medicaid Innovation, or the Medicare Innovation Center. And this is a new organization. It was created as a part of the Affordable Care Act, and it didn't exist before that. The DCE REACH program is one of about 54 or 55 different innovations that have come out from the Center for Medicare Innovation since it was conceived in 2010. And most of those were stopped as being, I mean, almost all, I think 4 weren't stopped. Most of those were stopped as being, of the 54, as being just bad ideas. So the program, the center today is headed by a woman named Liz Fowler. She started there about a year ago now. She comes to the Center for Medicare Innovation from a career that spanned Johnson & Johnson, from WellPoint, the insurance company. She was one of the actual authors of the Affordable Care Act when she worked at the U.S. Senate Finance Committee. And she's got a pretty long career, pretty impressive career, smart woman whose background largely comes from pharmaceutical companies and insurance companies. This program didn't start under her. It started under the head of CMMI, the Medicare Innovation Center, when it was run by a guy named Adam Boehler. Who is Adam Boehler? Well, he was a roommate of President Trump's son-in-law, Jared Kushner, and he ran the Medicare Innovation Center when the direct contracting model was first proposed in 2019. But before he went to the Center for Medicare Innovation, he came from a startup called Landmark Health. So Adam Boehler came to Medicare from Landmark Health, and then this new direct contracting program started, and Landmark Health became one of the first direct contracting entities. Well, he wasn't there forever. He left in 2020 and was replaced, I guess, by a guy named Brad Smith. Brad Smith ran the Medicare Innovation Center between Adam Boehler and Liz Fowler. In his background, he came from a place called CareMore Health, which is part of the insurance industry largely. And before that, so he worked for Anthem. He worked for Anthem, the insurance industry. But then he went to CareMore Health, which actually is now one of the direct contracting entities. So actually now he runs Russell Street Ventures, which is an investment firm that has lots of other people from Medicare Innovation Center. So these folks, it looks like this is a revolving door, and indeed, Xavier Becerra's Office of General Counsel warned that this program proposal, the direct contracting proposal, was actually referencing very specific entities like the ones that is talked about. And the General Counsel warned that this program was being designed in a way that raised very serious ethical concerns to benefit these specific companies. And several of them actually then went on, as was warned, to get these contracts. So who are direct contracting entities? Almost anybody. Almost anybody can become a direct contracting entity. A dialysis center can become almost anybody. Commercial insurance companies and largely private equity investors are becoming them. And these applicants to become these entities are approved without any oversight or approval from Congress, as was the entire program that we're talking about. Here's one example. Here's a direct contracting entity called Illumed, and they don't capitalize the I in Illumed. I don't know why, but they don't. So here's their leadership team. Why am I showing you that? To point out that only the one I've circled in red of all this dozen or so people, their leadership team has one person with a background in healthcare. None of the rest have any background in healthcare, and yet they're running this incredibly healthcare-centric organization. She's a professional nurse. And what else do we know about this particular direct contracting entity? Well, hooray, they just recently hired a chief medical officer. So now I guess there's 2 healthcare people. And where did Ilya get their chief medical officer from? They got it from Humana, the insurance company. So he has a strong insurance background. And when they announced that, then they were able to pull in more than $16 million from the investment community. The investment community is actually betting pretty heavy on the DCE reach intervention in healthcare. Why would Wall Street be investing in these companies that, as I told you at the beginning, is claiming as their mission to save money for Medicare? Why would Wall Street invest in companies that are designed to claim to reduce money for healthcare, for Medicare? Well, remember, here's how Medicare works. Medicare pays doctors through traditional Medicare and hospitals or doctors directly. And now we have a banker in the middle, the investment community, or which owns the direct contracting entities. And the bankers, of course, now the investment community owns the direct contracting entities. Why are they doing that? How do they make money? Because they're not doing it. They want to make money off of this, of course. And so one strategy they have is they can maximize how much Medicare pays them. There's a bunch of games. I'll show you sort of a high level of one of those. Secondly, of course, is they get prepaid to take care of you in Medicare now under this model. And the less they have to spend on your actual healthcare, the more they can retain of what Medicare pays them. So they're not eager to spend more. They can make more money by minimizing what they have to spend on patient care. And then this is perhaps the most frightening piece, is how they're growing, automatic enrollment. So let me tell you a little bit about all 3. First, maximizing the revenue. The trick here is that they need to get reimbursed as much as they can from Medicare, which means they need to make you look sick. The agreement is that if you're a sick senior, if you have a bunch of diagnoses, then Medicare pays them more for you. And if you're not so sick, they don't pay you as much. So they don't actually want to attract people that are sick. They want to attract people who look like they're sick. And there's an incredible set of games involved in making that happen. And we won't go into detail on that because it gets really, really arithmetically complicated, and I can barely get my head around it most of the time. Second piece is they minimize what they actually spend on healthcare, because they're allowed to keep, as I was saying, as profit or overhead, most, if not all, of what they don't spend on healthcare. That's new. That's never been the case in traditional Medicare. In traditional Medicare, there is, Part A and B, there is no middleman in there who makes more money by rationing or restricting your healthcare. That hasn't existed. And now, unfortunately, they are starting to exist in traditional Medicare. And then the last and maybe most interesting piece is how they grow through enrollment. So you've all seen ads like I'm showing you. Those, again, who don't have video, I'm showing a picture of one of the many examples of Joe Namath getting on the TV machines and telling us that we need to talk to him or his cohorts about Medicare Advantage. So we've seen that. The reason there are all these ads for Medicare Advantage on TV is because that's how they grow. They grow by a Medicare member thinking about their Medicare and being persuaded to turn their Part A and B over to Humana or over to Blue Cross or over to Centene or someone. So the Medicare Advantage, Part C, grows by people opting into it. And with that mechanism, with the TV ads, now roughly 50% of people in Medicare have chosen to go into that. But 50% of us have not chosen that because we actually don't like the idea of having a narrow network or having somebody tell me who I can go see or can't go see. We don't like the idea of having a middleman in our healthcare. So they're kind of stuck. There's half of us in Medicare that the investment community and insurance companies haven't been able to get their hands on. So what's going on, and this is kind of, what's going on is that Medicare, for this new program, Medicare is going through your medical claims. Medicare is going through all of the bills that doctors and hospitals have sent into Medicare for the last year or two. They're trying to figure out who they think your primary care doctor is, because they have that information, right? They don't need any television ads to do this part. And if Medicare finds that your primary care physician, or who they think your primary care physician is on the list affiliated with one of these REACH or DCE middlemen, They find out who they think your doctor is. They check your doctor against the list of reaches and DCEs. And if your doctor is on that list, without asking you, without by your leave, without anything, they automatically align you, they call it, or assign you into that new DCE or that new REACH program. So they're going through your medical claims. They're figuring out Medicare is, figuring out who they think your primary care doctor is. And without asking you or fully informing you, they're putting you in to one of these programs that I was just describing to you. They do have to notify you that they've done that. So you'll get a letter like the one that's on the screen right now. And it's, pretty hard to read. Notice at the top of it, it says, this is a required notice, no action needed, and then a whole bunch of fine print after that. I don't know about y'all, but when I get one of these letters, from anybody, that's, all this fine print coming up for a few pages, but at the top of it, it says no action needed. I don't, how many of us actually read those things? We don't. And so, yes, you're informed that this has been done to you, but, really, not really so much. But most importantly, say you've learned about this program and you get informed and you actually noticed this. When we met with Liz Fowler and the Medicare Innovation Center, we said, so what if a patient figures it out and they know that they're in and they don't like it? Can they get out? Can they opt out? Oh, yes. Oh, yes, you can opt out. Absolutely. All you have to do is find a new doctor. Really, all you have to do is find a new doctor. So if you don't like this program and you want to get out, no worries, just change doctors. Well, number one, it's hard to find a doctor that we like generally. You have to, it takes a while. It's not easy. And if you live in a rural or an underserved area, good luck changing doctors. Just good luck changing doctors. So I think that's a pretty rotten thing to say. And asking someone in traditional Medicare to change primary care physicians because you've changed how you're doing the finances, that's really undermining traditional Medicare's promise of free choice in providers. And it's not right. And perhaps even more importantly is that this is, a threat to Medicare and frankly will be contributing to Medicare's ability to stay in business. As I said, these folks are allowed to keep most of what they spend on your healthcare and make it as profit. They can actually keep 100% of the first 25% of what they reduce in spending. So all of that, and then big chunks of the rest. So they can keep a lot of this, and they call that savings, but they don't return those savings to you. They don't return those savings to Medicare. It's savings for them, not for patients or for Medicare. The middlemen can keep, as I said, anywhere from maybe 60 if they're really crazy, up to easily 75% of what they spend. That's a big deal. That's a big change. So traditional Medicare has no profit built into it. Traditional Medicare operates with a 2% overhead, which means in traditional Medicare, 98% of their budget, 98% of the budget in traditional Medicare goes into actual patient care. Medicare Advantage, it's not quite as good. There's about 15% of what we spend on Medicare Advantage that goes into Medicare Advantage's profits and overhead. They're allowed to keep up to 15% as profits and overhead, which is why we actually spend more on Medicare Advantage patients than we do on traditional Medicare patients. But 15%. These new REACH middlemen can keep easily 25% or potentially even as much as 40% of what they get on healthcare. So, the only way you do that really is by cutting care and by bankrupting the program. It's a threat to our future. Direct contracting, as I said, is in place now. It runs through the end of 2022, and then the REACH program starts at the very beginning of 2023. Last year, there were already 340,000 Medicare beneficiaries that had been assigned to a direct contracting entity, 340,000. There were 54 of these entities with 340,000 people. This year, we've gone from 54 direct contracting entities up to 99 today, direct contracting entities. And we've gone from 340,000 people, to 1.8 million Medicare members have already been assigned, none of whom agreed to it. We have no idea how many are going to be in 2023. We do know that every one of today's direct contracting entities has been pre-approved automatically to be able to roll into the 2023 program. Plus more are being accepted as applicants right now. Medicare has announced that there are no limits to how many more of these organizations can happen. There are no limits to how many Medicare beneficiaries will be pushed into one of these programs. They said that they reserve the right to stop enrollment if they think they have too many, but they've never said how many that is. And most importantly, Medicare has publicly announced, it's on their website if you think this is making this stuff up, because it sounds like it, I agree, but they've publicly announced that by the year 2030, every Medicare beneficiary and Medicaid people will be assigned to a program like this DCE REACH program. So if you're not in one today, just sit tight, and it's coming for you too. The good news is that we have been making progress at changing this. So as I sort of said at the beginning, earlier on, a handful of us doctors went to District of Columbia and met with several several members of Congress and their staff, and we delivered a petition to Secretary Becerra that had thousands of signatures saying, please stop this program. We met, I think as a consequence of our bringing this to their awareness, 54, I think it is, members of Congress wrote a letter demanding that Medicare stop this program. Senator Elizabeth Warren spoke out about this in a hearing, and we've had dozens, not hundreds, but dozens of articles and op-eds and letters and calls to Congress for action. So we need to do more. Here's just one example where Representative Jayapal pointed out that healthcare is this is coming under scrutiny, but rather than end the program, what happened is the next step was that President Biden gave it a makeover, a new name. And Wall Street said, here's what they think about the new name. One Wall Street analyst said this new name, these new reforms, the REACH program, this is one part public relations and one part modest revisions, but this should not tangibly impact the for-profit entities currently participating in the model. So Wall Street has said, yeah, they changed the name, but not to worry. And indeed, this new program keeps all the same flaws. It puts middlemen in between Medicare and providers, gets in your way. It maximizes revenues by upcoding in the way we sort of touched on. That creates a profit incentive to restrict care. They can keep more than 20%, 25% as profit and overhead. It automatically enrolls you, and they can include private equity investors and commercial insurers. So nothing so fundamental has changed in my mind, from the direct contracting program that we know and hate today to the new REACH program tomorrow, with no limits, like I said. It's big giveaways. If anything, the changes are in the new program are giveaways to industry. There's actually lower penalties if they don't control costs. There's actually lower penalties if they're found not to provide quality of care, and they don't even need to reapply. So they can just automatically roll into the program. There's a lot of lip service to this new program to equity. That's the buzzword. If a program improves equity, then everybody in the country wants that. So we're seeing they're calling equity washing, where programs that really don't do much for equity are focusing on, yes, we're going to improve equity. And indeed, that's what we see is happening here. There are equity incentives built into this new program that weren't in the current program, that actually will encourage profiteering more in the underserved communities, if you ask us. So REACH middlemen are going to get paid extra just to report the age and sex and whatever demographic data they have. They're going to get paid a bonus just for doing that. They'll get paid a bonus for signing people up from an underserved community, but there's no quid pro quo. There's no requirement on the back end for this extra money that they actually make sure that the person from that community gets any extra care. So it's just a bonus to sign you up, but nothing on no trade back that they have to actually deliver any health care. We're concerned about this. And the program to do the equity program, so the REACH program requires the new companies to describe their equity program. And if you don't have the monitor going, you won't be able to quite see this, but I've given you a screen capture of what the new equity plans that the programs have to submit looks like. If you've got a fifth grader at your house, you'll see that these plans look somewhat like the homework that fifth graders get assigned. These are really just fill in the blank worksheets. They're not, really robust plans. And if they're so committed to equity, the equity plans don't even have to be submitted until I think a year or two after they've started working as a REACH program. They have no accountability for actually improving equity. And it's unclear why they have this whole equity thing in it at all, if it's not just for what we're seeing, which is members of Congress pushing back now and saying, hey, this is pro equity. How can you, we like mother pie, we like the apple, we like coffee, and we like an equity program, but this is lip service and gloss. This isn't going to actually do this. The good news is the program. The bad news is this was created without an act of Congress. The good news is a program like this that can be created without an act of Congress can be ended without an act of Congress. So remember, these middlemen are in it for money, our money. Remember that they can keep much of what they don't spend. It's the wrong incentive and it's dangerous, and we should be alarmed, and it's really a bait and switch. You're being pushed into it without being asked, and you're being told to find a new doctor. But the good news is that President Trump or Secretary Becerra President Biden or Secretary Becerra could tonight stop this program if they chose to. It started without an act of Congress and can be ended without an act of Congress. And let me tell you, there's nothing that terrifies people in Congress more than a bunch of angry senior citizens saying, you're messing with my Medicare here, buddy, stop it. So you have an important voice in this. And with that, I think I'll stop screen sharing and we should have time for some questions and discussion. Oh, wait, hang on for a second. Sorry. Okay, sorry.
We have a couple questions in Q&A. I'm going to make them live. So our first one comes from Steve, who wants to know if he's been caught up in this, like maybe he missed the letter. How can you figure that out? What can you do about it?
It's a good question. So I had the very same question because, so I was wondering, when I was thinking about this stuff last, I was wondering, was I in one of these? So, I called my doctor's office and they didn't know anything about this. They didn't know. So I thought, well, I'm going to call 1-800-Medicare, right? I'm going to call 1-800-Medicare. And I've never had to call them before. And I was really pleased with the service that I got. They were really talking to us and they were nice. They'd never heard of direct contracting or reach. So we spent about 20-25 minutes with the agent going to supervisors and managers and all this, and we went back and forth for almost a half an hour there. And they concluded that they didn't have any records of the program. And 1-800-Medicare tells me that 1-800-Medicare cannot tell you if you're in one of these programs. They don't have that database. And so you have to ask your doctor's office. And, so good luck with that.
And I would like to ask you, is there any sort of a publicly searchable list of the caregivers that are in these DCE programs?
No, there's a publicly searchable list of the names of the DCE programs. If you go to the Medicare Innovation Center's website and dig around, if anybody wants, I can help them dig around. You can get the list of the current direct contracting entities. There's 99. You can get the list of the current. You can't get the list of the unknown number for 2023. You can get the list of the current, but they're obscure names, to tell you the truth. You then have to do research to figure out, well, what's each one of these entities has its own set of medical groups, and to figure out which medical group is in which entity is not easy. And then to figure out, it's not easy. There's not like a list of here's the 1.8 million people who have been transferred into one of these. You can't, that's not publicly available. That's part of the frightening of this, is you can't be really sure.
Wow. All right. It looks like we've got some more questions. We have one from Tim. I'm trying to go back up in the chat here. What should people be on the lookout to make sure this isn't to make sure that this isn't happening to them?
Well, in theory, and I think they're probably doing this, although we have no reports about it, but in theory, everybody who has been assigned to one of these is supposed to get a letter from the direct contracting entity. So, watch your mail, and see if there's there and if it's in there. Of course, though, you can't get out if you're in. But so let me perhaps tell you what one of my biggest worries about this is as a patient. So it's kind of a good thing, but it's a good thing, bad thing. So because these organizations can make so much money, they're actually allowed to improve your benefits. So that's the good part of the good thing. So it hasn't started to happen yet. So I'm sort of projecting what I think is going to be the biggest problem as a patient. It hasn't happened yet, but they're allowed to say, you can, so if you're in one of these entities, you can still go to the entire network of Medicare. So Medicare Advantage, tells you, no, this doctor, not that doctor. A direct contracting entity does not take that choice away. You retain access to the full network of any Medicare doctor or any hospital. So that's, again, good news. The DCE or REACH entity makes more money if they can encourage you, lead you into using the REACH's network of physicians, and they can give their physicians in their network an incentive or a penalty if they fail, an incentive to preferably to have a preference to refer you within their network. So they can't say no to you going outside a network, but they can encourage you. And that's the easy part. The more, so you can say no to that. The more dangerous part, the thing you have to be on the lookout for, and that is why I'm really glad to be talking with you, is that they might tempt you to give up your Medigap policy. And that's what scares me. So, most of us who have Medicare, if we can, we buy a Medicare supplemental, because Medicare comes with co-pays and deductibles, and you can go bankrupt if you don't buy a Medicare supplemental policy or a Medigap. So I have a plan G, my mother-in-law has a plan F. So most of us do that. And we do it because of the co-pays and deductibles. So think about it this way, with what might be coming down the road, what I think is going to be coming down the road is that these REACH entities can't say, no, you can't go out, but they can actually lower or eliminate your copay if you stay inside their network. So if you're healthy and you're reasonably happy with the network that they give you, then you might be tempted to give up your Medigap policy. You might be tempted, if they do this, you might be tempted to give up your Medigap policy. And you're thinking, well, if REACH hasn't been so bad for me, until you get sick, until you get sick. And then it may turn out that the place you want to go, like my mother-in-law wanted to go from Florida to St. Louis, it may turn out the place you want to go isn't in their preferred network. And yes, Medicare is telling you the truth that you can go anywhere you want. But if you don't have a Medigap policy, I mean, if my mother-in-law spent, let's say her healthcare cost $100,000, which is probably the ballpark, and if she had to pay $20,000 of that, that would have been on the table for making the decision of, do I go to the place that knows what they're doing? Or do we go to the place that actually has never done this before? So if you give up your Medigap policy, you might be in trouble. And you have to know, and most people don't know this, but there's no guarantee you can get your Medigap policy back. There's no guarantee you can get it back. The Medigap policies are required to sell you a policy at the same price they'd sell anybody, required to not ask you your health status or any of those things for the first 6 months that you're in traditional Medicare, or 12 months in Medicare Advantage. They're required to sell you a policy. But if you've been in Medicare for more than 6 to 12 months and you don't have a Medigap policy, they don't have any obligation in most states to sell you a policy. They don't have an obligation to sell you a policy in Missouri. So you could absolutely be in the circumstance where you're assigned to one of these REACH organizations. The REACH organization hasn't started doing this yet, but they're going to, because it's within their contract. They can. They could lower your copays if you use their doctors, their preferred doctors. You'll then scratch your head and go, why am I paying $200 a month for a Medigap when I've already got, this great thing? And that'll work just dandy for the year or 2 or 10 years when you don't get sick and don't need to go outside their network. So my biggest warning to you, if you're assigned to one of these, is hang on for life and death. No matter what they tell you, hang on for life and death to your Medigap policy until we fix the bigger problems. That's a long answer to a short
great
question.
Answer to Ruth's question about whether or not you should get a Medicare supplement or not. It sounds like the answer to that is probably.
If you can, yeah.
So we also have a question from Kathleen. She wants to know what will happen to veterans who are on the TRICARE program.
This does not affect them directly. So
Okay.
This has not yet spread into TRICARE. This has no direct effect on them.
Okay, and
as
then
far as my reading.
All right, good. Betsy says that I have a traditional Medicare and a supplement plan. Is the profit margin in the 2% of your pie chart? And I think that she's actually referring to the overhead costs there.
Yes, right. Yeah, the overhead. Traditional Medicare has no profit. It's a part of the government. Doesn't make a profit. And the 2% is the overhead of traditional Medicare Parts A and B. The supplements have a profit built into them too. I honestly don't know how big that number is, but it's pretty small from what I understand.
Okay, and then we have one more question, wanting to know, do you think Medicare Advantage plans paved the way for more privatization? And can you talk about that a little bit?
Oh yeah, it's a story arc. I mean, it's this. We didn't go from 0 to 100 overnight. Medicare, there's been actually a 50-year trajectory of Medicare being taken over by private industry. So, Medicare was enacted in 1965. 8 years later, in 1973, the Medicare or the Health Maintenance Act, HMO Act, was passed. Didn't privatize Medicare, but it created this whole prepaid healthcare system, trying to further privatize all of healthcare, and then a whole series of stages of the ACO community to there's a whole long list of these things that have come out as moving Medicare more and more towards privatization. The biggest one is indeed what you said, Medicare Advantage, and its prequel, Medicare Plus Choice. These were all incremental steps, and now they've reached nearly half of Medicare members. And I guess they're getting tired of growing patient by patient, and they wanted to sort of move, millions of people overnight. I mean, it's just, so yeah, it's a continuum in my mind. They are different, but it's a continuum.
Yeah, absolutely. Okay, and then Kevin would like to know, are we talking only about my primary doctor's DCE participation, or other doctors like specialists that my primary doctor may refer me to?
Yeah, it's both. You're assigned to a DCE based upon who Medicare determines your primary care physician to be. So the game for the DCEs is to get these contracts with primary care physicians, and they're luring us doctors in with all kinds of extra money and less work and all kinds of very tempting things. So the game is for the DCEs is to acquire the practices of the primary care doctors. But the contracts don't stop at the primary care doctors. They're building their networks, right? They're getting the cardiologists that they want, and they're offering that cardiologist more volume. More patients will direct you these patients if you'll take a slightly lower fee schedule. So it's a trade-off, exactly the same way Medicare Advantage and the HMO industry grew. So you're assigned by your primary care doctor, but the DCE network is including more than its primary care doctors.
Okay, and then we have a question from Brian. He'd like to know, would this get rid of open enrollment periods for supplements each year?
No, I mean, not until supplements disappear. So no, the open enrollment periods, those would continue. And you could, as I was saying, you could always switch to a different primary care doctor, but then you would need, you need to make sure you have your supplement, and supplements in, I think, 46 out of 50 states. There is no guarantee that they'll issue you a policy if you apply for one after the first 6 to 12 months that you're in it.
Gotcha. And then I have a question from my mom. How can you tell if your care is already being upcoded? Is there a way you can watch for that? And is there somebody that you can report that to if that is the case?
That's a really good question. You'd have to see the bill that got submitted, and by your doctors or your hospital. And I don't think we tend to see these. We tend to see the service codes, get admitted, because the payment in the traditional world is based on what procedure your doctor did. So when they send you the EOBs, it usually has the procedures that were done and the payment structure. Here's the bill, here's all that. I don't think those statements usually include your diagnostic codes. And to be honest with you, I don't know how accessible that is. That's a great question.
Yeah, they can be really hard when you have regular insurance to get those diagnostic codes and the CPT codes and all of that separated. So I can imagine it's only harder when you're working through these entities that don't want to give out any of your information to you because they're trying to do a bait and switch trick. So we also have one last question. Oh, sorry, go ahead.
I think if you ask persistently, you can get a copy of that, but then good luck deciphering it too, because they're in numbers and codes. But yeah, I think you can, but you have to really push.
Yeah, I think so. All right. And then I think, just to be respectful of everybody's time, we'll take this one last question, which I think leads us in really well to the last portion of this. What can we do about stopping this program from happening?
And that may actually, funny you asked, Jamie. I haven't actually have a couple of slides about that. Let me actually maybe show you. Yes, I actually have. Perfect. Thank you. Somebody read my mind. So how do we stop these? So one simple answer, there's one website you can go to that has all of this information and lots more and tools that I'll talk about in a moment. So go to protectmedicare.net. Go to protectmedicare.net. And that's entirely focused on the DCE reach stuff, protectmedicare.net. And in there, as an individual person, you can do a few things. First, you can learn more. But secondly, we've actually put together a petition that has many thousands of people that have signed. And it's like a tsunami, you know, the more people that sign this petition, the more powerful it gets every time we point to it. And we point to it repeatedly to Congress and to the press. And every time we point to it, it's got a bigger number on it. So, you know, sign it. So go to protectmedicare.net, learn more. And when you think that actually you agree, how do you not? Then sign the petition and get your friends to sign the petition. Share that petition. So go there and then write letters. You know, we need more presence in the media. You know, we've written lots. Our organization has. We've met with lots of journalists, but everybody, you know, it doesn't have to be anything. You know, it can be as sophisticated as you want, or it can be as plain speaking as you want. And if you go to protectmedicare.net, the one place you need to know, protectmedicare.net. We actually have some guidelines and some talking points and tips, and, you know, just put it in your own words and write letters. And then secondly, if you're in an organization, in addition to being in MRCC, if you're in an organization, any other organizations, you know, we have organizational letters that you can sign on to. So ask your organization, again, at protectmedicare.net. So ask your organization to sign on to the ACO REACH Medicare privatization letter that you can find on the ACO REACH on the protectmedicare.net site, and then share that petition with your members. So again, learn more at protectmedicare.net.
Okay, fantastic. Thank you so much for that. And if anybody didn't hear protectmedicare.net enough times, it is in the chat, so you can grab that, keep that link for you, so you can use it later. And in addition to the great action steps that Ed just mentioned through protectmedicare.net, MRCC has also launched a direct letter campaign to Secretary Xavier Becerra. Dina will be dropping the link for that in the chat in just a moment, and that will take you to our page where you can put in your information and customize a letter to Secretary Becerra right now, letting him know that Missourians want to strengthen Medicare, not weaken it. We suggest that you do this like now, while the information is still fresh in your mind, and add your own story of why Medicare matters to you and your family and your community, and what you're most concerned about with this REACH program. Remember, the Biden administration has the power to stop this, but they absolutely have to feel the pressure about how unpopular it is to motivate them. That's the only things that makes politicians do anything, is remembering that we get angry about some things, and some things we just won't stand for. And I think that we can all agree that Medicare is one of those things. We will not stand for these kind of attacks on Medicare. So on that note, we recorded this webinar and we'll be putting it up on our YouTube, our website, and our Facebook page. So please help us to spread the word to your family, friends, and neighbors. Don't hesitate to reach out to us if you have any questions. And Dina has dropped the links to both of the takes action steps in the chat, and we will be sending around a follow-up email with these details as well. Thank you so much again for joining us, and thank you for standing up to protect Medicare, and have a wonderful afternoon and weekend. Thanks, everybody.